I'd like to thank everybody for joining us today. We will probably have a couple more people joining in while we're doing the introductions, and we're very pleased that a number of people are probably at sites where they're in a boardroom and are listening to it together. This is the last of the first series of our Research to Practice in Acquired Brain Injury webinars, and we are going to host more in the future, so we hope that you'll all be interested in the follow-up series. Today is on substance use, ABI, and mental health, looking at screening and treatment models. I'd like to introduce myself. I'm Corinne Kagan, the Senior Program Director at the Ontario Neurotrauma Foundation. ONF is a health research organization, and we focus on the practical application of research. Our work aims to advance, gather, and apply research knowledge, and that is to improve systems of care, outcomes, and quality of life for people with brain and spinal cord injuries, as well as increasing the effectiveness and use of prevention. ONF works with stakeholders and partners in Ontario and across the country and internationally. We pride ourselves on our relationships and our ability to initiate activity and network with many, many experts and organizations in neurotrauma, as well as related fields. ONF receives its funding from the Government of Ontario, and we have existed since 1998. We always say that we have provincial focus but national reach. In the area of acquired brain injury, we are proud to be the go-to organization for research knowledge and guideline development in Ontario and far beyond. Our speaker today has become one of the country's foremost experts on ABI and comorbid issues of substance use and mental health. To me, her name has become synonymous with SUBI. I'm sure she would be embarrassed at the fact that I'm calling her one of the country's foremost experts, but she is. Dr. Carolyn Lemsky is a board-certified neuropsychologist who has 25 years of experience working in rehabilitation settings in the U.S. and Canada. For 15 years now, she's been at the Community Head Injury Resource Services, which is c.h.i.r.s, where she's been the clinical director. c.h.i.r.s is a Ministry of Health and Long-Term Care funded agency, and it is designed to promote community reintegration of persons living with the effects of ABI. At c.h.i.r.s, Carolyn maintains an active clinical practice along with administrative, research, and training activities. For the past 8 years, she's been the director of the Substance Use and Brain Injury Bridging Project, a research and knowledge transfer initiative that is funded by ONF. Along with her partners at the Center for Addictions and Mental Health, she's trained over 2,000 mental health, addictions, and ABI providers in cross-training and has promoted the development of a more accessible, shared care model that breaks down the policy barriers often affecting people with comorbid issues. The SUBI program is responsible for initiating screening for brain injury at c.h.i.r.s, which is a wonderful piece of progress and very welcome to all of us in the ABI field. And the SUBI program is also the first Canadian pilot treatment program for comorbid ABI and addiction. Products include a provider's training manual and client workbook. Her recent work in collaboration with mental health partners is leading to a similar approach towards more accessible shared care models that break down the policy barriers. Without further ado, Carolyn Lemsky.
Thank you, Corinne. I just want to make sure that you guys can hear me and that I've accurately taken off my mute. Can you hear me?
Yes.
Okay, great. So thank you so much for that introduction. I can only hope that I live up to it in this talk. We have a couple of polls that we're going to initiate here, just so that we can see who is in our audience. And while we do that, I'm actually going to move to my acknowledgments. I do want to thank the Ontario Neurotrauma Foundation for being such a great champion of the work that we've been doing and for providing all their support. I'd also like to thank Judy Gargaro, who's been the project manager for some of the projects that I'm going to be talking about today. And I want to make sure that I acknowledge our partners in these research projects. Mohammed Basha from Reconnect and all the fantastic people at Reconnect who are responsible for the ACT Team project that I'm going to talk about today. And at the Center for Addictions and Mental Health, recently Peter Selby has become a great champion. Dr. Peter Selby is the Medical Director of Addiction Services at CAMH, and also Tim Godden, who's been a longtime supporter of the project. And our partners in Ontario c.h.i.r.s, and I'm hoping at the end of this presentation we'll be talking not about an ONF-funded project, but one of the spin-offs that I think illustrate as a part of the objective of this talk, how we can use this information to start to make changes in the services we provide. And I'd like to put out my acknowledgement to Dr. Omar Ghaffar there and the fantastic people in the neurobehavioral, or the neuropsychiatric as it's called now, team there. So today, I'm going to be focusing on just a couple of the projects that we've worked on. The first from the Substance Use and Brain Injury Bridging Project, and that will be the screening for brain injury at CAMH. And I'll also be talking about the Assertive Community Team Treatment Integration Demonstration Project that I mentioned just a second ago with Reconnect Mental Health Services. So I'm just taking a look at the results of the poll for what settings people primarily work in, and kind of as I expected, most of us are in brain injury settings. And so I'm going to put this question to you, and maybe, yeah, David's got that up now. Do you think that brain injury should be included in the national or provincial mental health and addiction strategies? Now, if you're not familiar, these strategies are white papers that are generally formulated by a group of experts and providers in the area, and they are intended to guide, wow, we got a lot of support for that. I'm just looking at the findings. But these strategies are intended to provide a framework for which programming and funding decisions are made. And I have an excerpt here from the national strategy, and one of the subpoints, 3.3, does specifically address providing better access to intensive acute and specialized services when they are needed by people living with severe or complex medical health problems and or illnesses. So that's sort of an introduction to that section. And then the closest that we get to a mention of brain injury there is improving coordination of services for people living with mental health problems or illnesses who have developmental disabilities or neurodegenerative disorders, and increase skills and knowledge for those who provide services to them. And it's a little disappointing to me that brain injury isn't specifically mentioned there. This is the Ontario strategy, and in Ontario it's not a separate mental health and addictions, but a combined strategy there. And both strategies value improvements in access and integration of services and the early identification and treatment of disorders. And I wanted to start by thinking about this because it might be a little bit controversial, although I guess not in the group that we have today, that I do believe that brain injury does belong on the mental health and addictions agendas, both provincially and nationally. And I'll try to make that argument as we go along in the talk. I noticed that there's a couple people who are having difficulty hearing. I'm hopefully going to try and resolve that. Okay, so all of the projects that I'm going to be talking about today and all the work comes from a particular context, and that's Community Head Injury Resource Services of Toronto. And for those of you who might not be aware of who we are, c.h.i.r.s is a ministry-funded, community-based service for people who are living with the long-term effects of acquired brain injury. We are, the core of our services are basically outreach services and residential services, but we also have a very active day program, and we have employment services as well as a growing clinical service. All of our clients come to us usually 2 or more years after their injuries. And what we were seeing at c.h.i.r.s is that roughly 1 in 3 have a diagnosis of serious mental illness or were using mental health services when they were referred. And in this context, we're using the definition of serious mental illness that's in use in mental health settings. And that is problems that include psychosis and are generally acute enough to require intensive intervention and sometimes hospitalization. That's a pretty high proportion, and roughly 1 in 2 in 5 c.h.i.r.s clients have experienced some ill effects of substance use in the post-acute phase of their recovery. And that would include problems like episodes of substance use that have resulted in additional injury or some contact with the law or other adverse event, all the way through to addictions that were perhaps reoccurring from the pre-injury period. And then about 1 in 5 require active supports to address either or both problematic substance use or a serious mental illness. So about 20% of our clients are needing active intervention. So what we were doing with all of these projects is addressing an immediate clinical need. And in most cases, these weren't basic research projects, but rather knowledge transfer projects. So we're trying to apply existing evidence-based best practice, identifying them and figuring out how we can implement them. And trying to make the best use of existing resources for our clients rather than, of course, waiting for additional funding to occur. And so to do that, we had to figure out who had the know-how and the person power and how to get the right people in the right place at the right time. And since we've been doing this work over the past 8 to 10 years, we started to come to understand that there are marginalized populations outside of those that might actually achieve a referral to c.h.i.r.s that might actually benefit from increased capacity in the system. And we were kind of hoping to identify who those folks are and then figure out best ways to increase the capacity within the system. Now, of course, the c.h.i.r.s experience is pretty well in keeping with the literature related to ABI and long-term mental health difficulties, and I'm not going to go through these data in any great detail. But both longitudinal studies that follow a person from the time of their injury forward, as well as cross-sectional studies have shown that as many as 80% of people living with traumatic brain injury meet the criteria for a primary psychiatric diagnosis sometime in the post-acute period, and in this particular study that we have cited by Hibbert et al., 7 years post-injury. People living with the effects of TBI compared to age and sex-matched controls have psychiatric illnesses, have more psychiatric illnesses both before and after brain injury. And it's a fascinating read to look at the literature and realize that that's true also for schizophrenia, bipolar disorder, and some disorders that also have a strong hereditary component. And comorbidity is pretty common. In the example I've got here, about 50% of individuals with TBI have also been found to have generalized anxiety disorder. But we also know that substance use and brain injury and mental health problems often come as a triumvirate. So if we look at the relationship between mental health and addictions and brain injury from the lens of mental health and addictions providers, a substantial proportion of these folks are finding their way to those services. And there have been a series of studies done across North America that have shown us that over 20% of the people seeking services for addictions have a history of brain injury with loss of consciousness. And these data actually mirror our own data that I'll be presenting a little bit later. But there's really pretty much consensus at this stage that is the case. And when we look at the more complex subpopulations like those with mental health problems or involvement with the justice system, that number increases to well over half. And in one case, 70% of all these individuals have a history of brain injury with loss of consciousness. Over half of all the people who are served by housing support programs have a history of brain injury. And that these data are local. Dr. Topalovic, Baranek, and the research of Stephen Huang and Angela Cohen-Antonio have all shown us that people who are served in housing programs have a strong history of acquired brain injury. About 12% of those actually have moderate to severe injuries, and 20 to 50% of people who seek treatment for mental health issues have a history of brain injury, and about 15% of those would be moderate to severe injury. And of course, here's some more local to Toronto data from Gabriella Ely about the strong impact of what we might think of as mild or inconsequential concussions, and how a history of concussion is actually associated with an increased risk for psychological distress, attempting suicide, and taking prescribed medications. And the numbers here are adjusted risk estimates. Now, at c.h.i.r.s, we've been really blessed to have strong links to neuropsychiatric services, and in particular, we have a neuropsychiatrist, Dr. Chan-Sayon from Toronto Western, providing regular consultation to our program. So we are able to get lots of support. But when we think about the system as a whole, and we think about trying to get services like a structured anxiety disorder program or intervention for something like an eating disorder, what we find is that most services are not designed to manage complex co-occurring disorders, and that would include, of course, brain injury. We've also encountered stigma, and stigma coming from really all sides of the equation when we try to make referrals into the mental health system. Sometimes the stigma comes on the part of our families and clients who'd rather not get their services from the mental health or addiction system and would prefer to be served by the ABI system. But there's also stigma on the other side, and this may in part be related to limited resources, but providers would generally prefer to choose those clients whom they feel they would have the best opportunity to make gains with. And very often, people living with the long-term impact of brain injury are viewed as more difficult to serve or less likely to benefit. And then there's also the stigma related to increased potential for aggression or violence or unpredictability. And in both service sectors, the ABI service sector and in mental health, and our training, we certainly encounter this. There seems to be a limited knowledge of what providers can do to modify their services and accommodate those individuals who do have complex co-occurring disorders. So each of these projects has been designed to address systems gaps in one way or another. One goal of the SUBI project, for example, has been to raise awareness. And initially we were doing that exclusively through education. But what we found was using data from other jurisdictions tended not to be that compelling. And it was from that experience that we learned that screening is a really important component to any effort to raise awareness. And of course, common sense would tell you it's necessary to do the screening to determine who requires the adaptations in service. So education and screening were very important components, but we also wanted to increase access and capacity. And so to do that, and another big piece of learning from these projects was that stigma really is an important barrier, and we really had to deal with that head on. And we also had to do training to increase capacity in each of the service sectors. And then another mandate of the projects is to identify promising treatment strategies. And for that, we developed intervention pilots. And we will talk about that, or I'll be talking mainly about the first two of these. So the first project I'm going to be talking about is the Center for Addiction and Mental Health Screening Project. And I should say that the relationship with CAMH goes back more than 10 years when we first started to try to do some co-treatment in that system. And roughly about 7 years ago, we decided that it would be a worthwhile enterprise to do training at do training and screening at CAMH as an awareness-raising exercise. And so in an initial group of about 300 referrals, we did find that there was about 20% positive rate for brain injury with a loss of consciousness. And from that experience, we decided to undertake a more formal screening program at the Center of Addictions and Mental Health. And that resulted in integrating the Ohio Valley Brain Injury Identification method into all of the assessments that occur at the main assessment site for the addictions programs, which is White Squirrel Way. So a total number of, and these are data from actually the first 2.5 years of that project. We now have an additional roughly 900 screens that we're going to be adding to these data before we rate them up. But from this initial 2.5 years, we approached 2,900 individuals. We managed to get full screens on 25-21. And here is a screenshot of some of the findings. And I think the first thing that becomes evident is that roughly a quarter of everyone who comes to CAMH for addiction services has a history of brain injury with loss of consciousness. 19% of them are one or more injury with loss of consciousness, and 5% two or more injuries of loss of consciousness. So that's just a history of injury with loss of consciousness, irrespective of how severe the brain injury itself was. About 28% of the injuries with loss of consciousness occurred before the age of 15, and that's something important to keep in mind as we go forward here. Now, the other thing we had access to with the screening data were the assessment data that were collected at the same time of the screening as a part of CAMH's addiction assessment. And these are data here from the Addiction Severity Index. And one of the indices are calculated based on lifetime substance use in years. And what we see is just for the fact of history of brain injury with loss of consciousness, one or more than one, what we find is that there's a significant relationship between more substance use or more years of substance use, more years of alcohol to intoxication, more years of cocaine use, cannabis use, and more years of lifetime delirium tremens, and these are the neurological symptoms of withdrawal that occur. Now, if you actually look at mood symptoms in a lifetime, and you're just now here still looking at whether a person had one or more brain injuries with loss of consciousness, you see a significant effect for suicide attempts, suicidal thoughts, anxiety, and depression. So that green bar are the folks with the greatest report, and they are the ones with two or more brain injuries, and the red one brain injury, and the blue bar no brain injury. And the same setup on this slide, only here we're looking at violence and difficulty concentrating. So we continue to see that in symptoms, if you have a history of brain injury with loss of consciousness, you're more likely to report significant psychiatric symptoms. The same is true for previous episodes of inpatient treatment. And this is an important thing to think about because it gets at the question of whether or not people with brain injury actually receive services in the same manner as people without a history of brain injury. So you see that with no history of brain injury, there's on average, less than one episode of previous care for addiction to alcohol and for drug treatment. And that number rises to 1.25 on average with one ABI and one for drug treatment. And with two or more ABIs, it rises further still. And these effects are certainly significant. And here we're just counting the number of brain injuries. But if we actually take a look at brain injury load, and what we do is actually weight the brain injury
by the severity, and for severity we use as an index the period of loss of consciousness. And we actually take a look at sort of the load of brain injury for an individual. And here I'm going to focus on the red line, and the red line is alcohol treatment. That with no TBI, your history of previous treatment is on average less than 1, and that's very similar, not significantly different to an injury but not having a loss of consciousness. But if you have a mild injury with brief loss of consciousness, that number creeps up to nearly 1.5 episodes of previous treatment. And look what happens if you have a moderate injury or more than one mild injury. It goes up to about 2.5 times the previous episodes of previous care. And then, of course, it falls back down for severe or multiple injuries of lesser severity. So interpreting these data, and I should say, I'll go back to this slide, I should say that the blue line represents drug treatment, and although there is an effect for brain injury severity, it's not as marked as it is for alcohol. And here I've taken a slide that was developed by Dr. Peter Selby because he helped to present these data at the American Academy of Rehab Medicine. And I think it's important to look at how somebody from CAMH actually looked at these data. And his interpretation is that middle group with moderate injuries may be those with significant enough cognitive impairment to have difficulty in benefiting from services at CAMH, but not so much impairment that they were readily identified as having a special need. So these were the walking wounded, and that was the phrase that he used, and he talked about the fact that if you don't screen for brain injury, what you don't measure, you don't see. And so these are people who might be failing out of treatment because of their undetected brain injury-related needs. And these are people who are mildly enough injury that 2 or more years post-injury, they fall off the service wheel and they have less support, whereas the people with more severe injuries might actually 2 or more years after injury have adequate supports around them and have modified treatment, and they seem to be doing a bit better in mainstream treatment programs. An important finding, I think. It was also important that when Dr. Selby was looking at the findings of this, it was his conclusion that integrated treatment to simultaneously treat substance use and TBI was needed. And actually, we're in the process of looking at how we can accomplish that within the CAMH system. So other findings from that treatment pilot or the screening pilot were that they found that it was easy to integrate the screening process into the electronic medical record. And it was his conclusion that roughly a third of all of the folks coming through CAMH's addiction doors have some neurological cause of for affecting their engagement in treatment, and whether that's acquired brain injury or a dementing illness or an illness that's associated directly with the impact of the substance use. And it was his conclusion that for that entire treatment group, we really need to adjust treatment accordingly and provide staff education, modify treatment goals, and look at specifically how pharmacological and biological treatments can be applied in this particular subgroup of clients. So we feel that motivating change was really important, and when we fed back these data to the assessment unit and to CAMH community in rounds, the comments that we got were that we are serving the same clients, that CAMH does have something to offer to these folks, and that some changes in service may be required. And that feels like quite a culture change from back in the beginning when a history of brain injury wasn't regarded with any special treatment. And if a moderate to severe brain injury was reported and the referral came from the brain injury sector, there was a reluctance to take on these clients. So Dr. Selby in the ACRM, American Congress of Rehab Medicine, talk that we did last fall made the comment, it's a case of the mouse teaching the elephant a lesson. And we were very proud of that. CAMH is a large institution. It is the complex amalgamation of 4 different healthcare institutions, 530 inpatient beds, 3,000 staff, huge, right? And an operating budget of over $300 million. And c.h.i.r.s, of course, has outreach in residential beds and an operating budget of just over $9 million. So much, much smaller, even though we're one of the larger community-based providers. Now, on average, on the addictions and the mental health sides combined, CAMH receives about 160 referrals per month. Now, if you think about what that means in terms of the data that we've already talked about, we can expect that there would be at least 60 referrals with a history of ABI significant enough to actually have an impact on care. Now, our new neurobehavioral program, which in Toronto is the only one that we're aware of that's brain injury based, specifically in the community, designed for these clients, can accept 24 clients, and we're funded about $375,000 a year. Now, we know that there are other specialized services and inpatient services, but even so, I think it's a fair comparison to say that the relative size of the ABI system to the mental health system can be represented in this graphic. So we think that screening for brain injury is an important step in motivating participation in integrated care, and we would encourage folks who have potential partnerships with brain injury or mental health and addictions agencies to encourage them to begin screening for brain injury and to begin partnering with them to determine the best ways to collaborate with care. So now I'm going to switch gears a little bit and talk about the mental health side of things. And in this project, we were looking at joint treatment using a mental health model. And the mental health model that we chose to look at was assertive community treatment teams. And the reason for that is ACT teams were originally developed in the 1980s to address that group of very complex individuals who don't seem to benefit very well from traditional hospital-based or office-based care. And actually, ACT came to Ontario through the efforts of Drs. Hugh Lefebvre and our own Gary Gerber from brain injury circles in the early 1990s. Now, an ACT team is an assertive community outreach team, and it has specific characteristics and a specific model that is to be followed to be considered an ACT team. There are about 74 of these across Ontario, and I believe they're found in every LHIN. So that makes it a particularly attractive trial, because if this were to prove successful, then certainly we would have a model that was scalable and realistic across Ontario. So what is an ACT team exactly? It's a professional multidisciplinary team that includes psychiatry, nursing, occupational therapy, social work, substance use specialists, employment specialists, mental health specialists, including counselors, rehabilitationists, psychologists. So it's a transdisciplinary model that includes and the teams themselves are designed to have a low client-staff ratio of no more than 10 to 1. And at least 75% of the support is supposed to be offered in vivo, which means not in an office and not in an institutional setting, but in the community where people are going about their business. And the services are designed to be flexible, and so you're supposed to be able to come back in and out of care as the needs and intensity are determined. And service is supposed to be offered on a 24-hour basis, 7 days a week, so there is crisis management available. And psychiatric services are integrated into the care that's offered. Clinical supervision is offered by people who are actively involved and have firsthand knowledge of the client and family. So this is a treatment model in which experienced and senior clinicians are directly involved with the outreach services. So we found this particularly attractive because for many of our clients who were living with serious mental illness and brain injury, that they were very crisis prone and we didn't really have good access to 24-hour crisis services. We also had limited access to nursing and the kind of community psychiatry treatment that is familiar with mental health law and can use things like forms and community treatment orders effectively. And there were also some mental health specialists that were initially missing from our c.h.i.r.s team, which included substance abuse specialists. Now, although it's a very attractive model for the clients that we were serving, the specific instructions and the specific manual for implementing ACT services, and this is a direct quote, indicates that clients with other psychiatric illnesses are eligible depending on the level of long-term disability. So if you have a great deal of disability, you're eligible for that care. But individuals with a primary diagnosis, such as substance use disorder, developmental disability, and organic disorders, and in this context, organic disorders includes organic personality disorders or brain injury, are not the intended client group. And we were aware that across Ontario, there's a great deal of interpretation of this particular requirement of ACT teams. There were some that unknowingly accepted people with acquired brain injury, and once they learned about it, dismissed. There were some that kept these folks in service. There were others that actually had some links to brain injury services. But certainly, it wasn't a consistent practice, and in Toronto particularly, our experience is that if a referral to an ACT team came from an ABI provider, those clients were often not accepted into care on the basis of this. Now, our partner, Reconnect, can almost be, it's a very c.h.i.r.s-like organization right down to the logo. They also use a butterfly. And they offer case management. Now, it's a mental health context, so they had specialized programs for developmental disability, forensics, mental health and justice, and elders, in addition to their ACT team. They also had employment services, and residential beds that they had were mental health and justice short-term crisis beds. And here's a screenshot from their website. Now, for this project, we only actually looked at co-managing 5 clients because that actually makes up just under 20% of their whole team complement, and we didn't want to overwhelm them with this project because they already had certainly an existing caseload. So 3 of the clients were c.h.i.r.s ABI network referrals with a primary diagnosis of acquired brain injury with psychiatric impairments, and sometimes the psychiatric diagnosis predated the brain injury. And then 2 referrals that emanated from ACT, and these were clients that screened positive for TBI with loss of consciousness. And what's important to realize is that all of the clients met the criteria for ACT participation. They included severe mental illness by the definition used in the Code of Practice, and they were heavy users of ER and hospital services in the past year. So they had more than 5 or 6 ER visits and more than, I believe it was 3 hospitalizations in the past year. So the questions we wanted to address were, can ACT support clients with an acquired brain injury without affecting their fidelity to the ACT model of care? What training is needed to prepare ACT to provide services to people with ABI? And what training is needed to prepare brain injury providers to work more effectively with people who have serious mental illness? And we wanted to be able to set this up so that a larger study could actually look at outcomes in this particular group. So before the clients actually came into service, we did a focus group to determine training needs and a survey to look at what people's thoughts and feelings were about working with the other new patient group, and a measurement of the ACT team fidelity. And the measure that we used for ACT team fidelity was one that's widely used in research in outcomes. We did the cross-training and got the teams ready to accept the new referrals, and then we implemented with the new referrals coming into service. And to do that, we had to look at communication practices, establish joint intake and assessment, plan how the service would actually be delivered, and delineate responsibilities. And this is, of course, very individualized because these were pretty complex clients. and then implement the shared care. And then in the follow-up period, we repeated the provider surveys, redid the focus groups, looked at how we could accomplish knowledge mobilization, and looked at client outcome. So one of the key findings that we came to in this study was that stigma was, in fact, a big part of client or staff members' attitudes as the clients were being referred into services. So on the brain injury side of things, our providers at c.h.i.r.s were worried that we wouldn't be safe, that clients with serious mental illness might be unpredictable, they would be harder to work with, that we wouldn't be able to help them. Similar concerns arose for brain injury folks on the mental health team, but they also worried that clients would take too much time, that they wouldn't be able to learn, and that their physical disabilities would require more care and might actually interfere with their ability to serve the total group of clients that they were responsible for. Now, as a result of our focus groups, we determined that core competencies needed by the mental health sector included how to screen for acquire a brain injury, recognizing how cognitive impairment presents in community-based settings, and basic cognitive compensation strategies like simplifying information, modifying the environment, providing cues and prompts, and reminders and calendars. All of those things were discussed and trained using the kinds of contexts in which ACT team provides their services. So these were all very much practical, community-based types of interventions. The core mental health training competencies for ABI settings were determined to be suicide prevention, screening for and recognizing psychiatric disorders, screening for substance use disorders, and then some counseling strategies that are more widely trained in mental health and addiction settings, including motivational interviewing, an better understanding of mental health resources, and I really should include here also mental health law, in other words, the use of forms and community treatment orders, and managing unusual beliefs and behaviors. So I'm going to talk very quickly about the screening data from Reconnect, and I'll tell you that originally the plan was just to screen the ACT team, but as we started to combine our services, it was determined, actually at the request of the Reconnect team, that we conduct screening throughout the agency. And I think we managed to touch roughly 80% or approach roughly 80% of Reconnect's clients at that time. So about 160 were approached, and of those, 86 said that they had a TBI. That's a little more than half. And no TBI was about 6. No TBI and no history of trauma was 64, and only 4 people actually refused the screening. When we actually took a look at the positive screens, we found that a high number of them had improbable or only possible TBIs, but about 58% or 50 had TBI with some loss of consciousness, and of those, 13 had moderate or severe injuries, and that amounts to close to 15% of the total population that they were serving. We also had a look at age and injury, and I won't talk about this in great detail, but I think what's really important to realize is that of the injuries that were identified with loss of consciousness, 42% or nearly half occurred before the age of 15 years. So certainly, long-term in the community, we are seeing that impact of childhood injury in adulthood. So when we looked at outcomes, I think the important things that we're looking at for the purpose of this presentation were the mental health workers' response to training and project participation. And I think it's really important that they were saying, we've been working with these people with brain injury without realizing it. And certainly after I do training in the mental health and addiction sectors, that's a comment that's frequently made elsewhere in the system as well. They were feeling that they should suspect cognitive problems when a client appears to be non-compliant or unmotivated, and that assuming that a problem is related to cognition and providing or developing compensation strategies is effective and less frustrating. So they found a benefit to taking a look at their clients through a brain injury lens. The brain injury provider's response to training, most of the clients are no different from the people we usually serve. And when we really think about it, some of the things that we're labeling as perhaps perseveration or unusual thought processes could also be labeled as delusional thinking. And so similar strategies for communication and support can be used with psychosis and other problems in brain injury. And they also felt that it was important to know how to recognize mental health problems and that they were probably more common than they had originally thought. And I think one other gratifying sentiment was that people felt more confident now that they understood how to respond to someone who says something that's suicidal or delusional. So the key findings, again, from this study were that 28% of the 154 clients screened at Reconnect had a brain injury with loss of consciousness, that acknowledging and managing people with brain injury on the team did not change the fidelity to the ACT team model. Teams reported a positive impact on their team functioning, and having two teams involved with clients sometimes resulted in communication difficulties. And so we really need to look at joint triage and developing our specialized services so that we could manage more of the psychiatric care as well. And outreach services were sometimes insufficient. And this was a comment that was made in reference both to the clients referred to the study and generally to the ACT team clients, and certainly we find this in a lot of our outreach clients at c.h.i.r.s, that supported housing is a pressing need for complex clients regardless of their diagnosis. Now, some key outcomes in terms of the system. c.h.i.r.s developed the neurobehavioral treatment team, and it uses many of the ACT practices and serves a very complex group. And we have now the ACT team as a resource to help us with that. We've also developed another resource in terms of hospitalization at Ontario Shores, and hopefully I'll steal a few minutes of this presentation to talk about that. c.h.i.r.s and Reconnect continue to cross-refer clients who would benefit from either primarily ABI or primarily mental health services, but for whom each agency might have some particular benefit. During the course of the study, they engaged our help to hire a behavior therapist who also seemed to have ABI experience, and we continue to provide training in ABI to staff members. And we now have training that can be used to support other mental health providers in recognizing and better managing acquired brain injury. So the upshot of all of this in our work has been that comprehensive, continuous, and integrated systems of care is really an applicable model of care for our clients who are living with comorbid brain injury or mental health and or addictions. Now, this model originated in the addictions world, and the authors here are Minkoff and Klein, actually originally in the late 90s, but this is the reference that I have on the slide here gives a good overview. And some of the important aspects of this model are that we should be looking at co-occurring issues and conditions as an expectation and not an exception when we're designing services and programs. That care should be client-centered, and that if it is going to be client-centered, it needs to be individualized. And so we have to have care systems that allow for flexibility. And treatment should be co-occurring, in other words, occur with timing that makes sense for the individual and sometimes at the same time. So it was the conclusion that the best practice intervention, and there is evidence in the literature to say that this works certainly for substance use and brain injury when they are comorbid, the best practice intervention is integrated dual or multiple primary treatment in which each condition or issue receives appropriately matched interventions at the same time. And John Corrigan, who's I think really the international expert in this field, has recognized that this model, comprehensive continuous integrating system of care, has application for people who have brain injuries and co-occurring mental health and addictions issues. So in this model, one of the backbones of it is the notion that care should be delivered based on the relative severity of each of the disorders, so that what you see in the upper right-hand quadrant of this model would be people with severe mental health disorders and a severe substance use disorder. Now, in each of the quadrants then, you'd wind up with specialized services that reflected the relative severity of each of the disorders. And where the mental health disorder was the more severe, then those services might actually take place with a greater mental health focus and in the current mental health system, but with support from substance use services. On the other hand, those services that have specialized concurrent programs would be considered to be a member of that upper right-hand quadrant. And I'm just going to briefly apply that to neurocognitive impairment. And if we look at both comorbid substance use and mental health issues, then we still wind up with a situation in which brain injury services should be able to accommodate some degree of mental health and addictions issues. And the mental health programs should be able to manage some degree of brain injury issues. And it's only those specialized and concurrent disorders programs where we're looking at having a very integrated and specialized approach that is truly, in essence, tertiary care. Now, within those quadrants, though, there is also the question of how to integrate services. But I'll get to that in a second. So what is integrated care? Okay. All the clients' issues are managed together in a single coherent plan. Cognitive and mental health and social features are all represented together. And the plan of action features the needs and most pressing concerns of the client and the family, and consideration is given to the healthcare's perspectives, but the core is really client-centered. And recommendation plans are made in consideration of the actual situation and the actual services that are available. But what are we integrating? Not only are we integrating across service sectors, mental health and addiction, but we also have to look at integrating inpatient, outpatient, and community services. And we have to look at how social services integrate with that. As a part of this work, we've been looking at models for how do we help people to better implement truly integrated care. And I think that this particular paper with Kodner and, I'm going to give this last name a shot, Sprevenberg, from the University of Maastricht, and Dennis Coder from New York University, when they looked at the components that are required for truly integrated care, they really were looking at it from an implementation perspective. And they talked very, very frankly about the fact that if funding is coming from two different streams, it really does present a barrier to truly integrated care. Administratively, there have to be certain components. I'll talk about those very quickly, organizationally, and in terms of service delivery, and also in terms of clinical model. So organizationally, and now we don't ordinarily think about brain injury services and mental health services being located together, but that turns out to be a really important feature of integrated care. And having things like discharge and transfer agreements, interagency planning, a service affiliation, all of those things. And remember, we're talking about having these in a truly integrated system, these organizational structures for cross-sectorial, in other words, across brain injury, mental health, and addiction settings, but also between inpatient and outpatient settings. Another thing that actually came to my attention as we were working in inpatient and more psychiatric settings is that in brain injury circles and in mental health circles, we use the standard diagnostic criteria differently. There's a different set of comprehensive assessment procedures. Care planning occurs very differently. And so having those, including medical records and patient monitoring, having all those service components harmonized becomes very important, and also, too, I think a big task, something that requires lots of careful consideration. In addition, we have to be thinking about practice guidelines. And needless to say, in most psychiatric settings, in most brain injury settings, practice guidelines that are referenced tend to be somewhat different, although both settings might want to have regular patient and family contact and ongoing support. And so the elements of joint training, centralized information, good case care management, multidisciplinary and interdisciplinary teamwork, and the accessibility to crisis services and integrated information systems are all things that we, I think, aspire to but can be difficult to implement. So I'm going to take a couple of the remaining minutes, and then hopefully people will be able to stay to have a bit of a discussion to talk about the c.h.i.r.s Ontario Shores partnership and how we used some of those criteria to actually begin integrating services. And now in this case, we're not talking about across sectors, but we're talking about inpatient to outpatient treatment. So the idea was to bridge inpatient and outpatient neuropsychiatric and neurobehavioral care, and using a client-centered single care plan spanning the specialty neuropsychiatric service and community-based supports. And in that way, improve access to evidence-based models of care, increase provider capacity by joint training, and inform policy, hopefully, by looking at outcomes. So the community referrals that we wanted to refer to the psychiatric setting were those folks who were having these repeat visits to ERs or repeat visits to community based psychiatric centers, and they weren't really getting their needs met in a coherent long-term way. And so these were people with multiple medical and behavioral difficulties whom we felt a secure environment could offer safety and a better opportunity for engagement, and also allow that kind of comprehensive assessment that would enable the development of a long-term structured plan. And the tactics we used, because a lot of times clients didn't want to go in inpatient, we're working with them for a long time to get them ready to go inpatient and doing a warm transfer so that I can say, I know the doctor on the other end. His name is Omar Ghaffar. He's going to be very helpful to you, and I can name the behavior therapist, and we work together, is really helpful in helping clients and families to accept that inpatient referral. Your team won't change. We'll be there with you, and the plan that we make and your discharge will be coherent. Now, the needs that the hospital were seeing, of course, were related to once they had achieved a good result with the client, getting the right supports lined up in the community, or clients who returned to hospital because their needs were not met in the community. And so we wanted to enable discharge by bridging the gaps in supports and then providing that real-time feedback to adjust treatment before it gets to the point that a rehospitalization is necessary. And again, the same tactics were proving to be useful. The warm transfer, and the team that it remains consistent through inpatient and outpatient stays. And a big part of our learning is that this treatment occurs, and perhaps across several inpatient stays, occurs in phases, and for the more complicated cases, takes quite a bit of time. We have to allow for an extended period of time during which we engage with the client to develop a working alliance and prioritize needs and create the treatment plan. We have to cultivate consensus among both the client and family and the team members about what the most important issues to address are. And all of that work has to be done before active treatment can actually be implemented with any hope of success. And now in that case, we've identified the cognitive behavior therapy, dialectical behavior therapy, in addition to applied behavior analysis, particularly antecedent management generalization training, and it should be its own bullet, medical intervention, which would include medication management, as well as models of family supports. All of those components seem to be very useful to this client group. And then doing the community integration with great care so that the discharge occurs with good feedback to the hospital-based setting. In an application for joint funding, we actually made the financial argument. And I won't talk about these data in detail except to say that we looked at the data over the last 2 years in the neuropsychiatric unit at OS, and found that there were close to 1,000 days of ALC, and that the in clients specifically who had a history of acquired brain injury. And we found that there could be, if these clients were supported in the community, a substantial savings, over $1 million over the course of every 2 years, and that specialized housing might also realize similar, although less, savings. So what do we have in place? We have common protocols, continuous monitoring, and regular engagement and support, and we are starting to harmonize the way we look at and diagnose folks. The service delivery is interdisciplinary, and administratively, there were some things in place to allow the co-location of services. So c.h.i.r.s staff members do have access to the physical plant over at OS. They have Ontario c.h.i.r.s tags. They have the same safety device that allows them to call for security for support, and they can have access to the recreational facilities there so that we can use those with the client while they are in-house. And that turned out to be a huge benefit because we get to know better what's happening in hospital, and we can be more a member of the team. We're also using OTN and teleconferencing to great advantage. Organizationally, we are formalizing a relationship with a memorandum of understanding. We have discharges and transfers that are determined on a case-by-case basis, and we are planning together for future services. And we're kind of hoping to get a joint proposal and look at outcomes in a more systematic way. So what are the research questions? How effective is intensive case management in reducing cost of care and increasing satisfaction with life in individuals with co-occurring brain injury, mental health, and addictions? And certainly that's the randomized control trial that I think is getting to be the next step here. Which elements are essential for ABI services? We have some ideas. And then I'd like to see some studies of some models that were developed in mental health but not actually assessed in brain injury populations. And these include community reinforcement and family training, which is a model of family intervention that was developed in addiction settings and has a great evidence base in that group, and dialectical behavior therapy, which has a growing research base in lots of populations but not much specifically in acquired brain injury. So I'm going to go back. That's the end of my formal remarks. And I was expecting to get a little more controversy over whether or not ABI belonged in the mental health and addiction strategy, but we can have a look at that poll again. So if you wouldn't mind answering, do you think that brain injury belongs on Canada's mental health and addiction strategies? And it looks like I have 100% agreement as the numbers are kind of ticking in. So that's the end of my formal remarks. And then, David, do you want to facilitate us going into more of a discussion mode if people have the time?
Sure. So we're just going to switch over to our discussion screen here. And if you have any questions for Carolyn, just type them in the chat and I'll read them out to her. Carolyn, you can start your webcam if you'd like.
I just saw the dot to do that. Hello. There we are. I'm feeling a little bit like a a radio talk show host.
So any questions for Carolyn's presentation, feel free to type them in. Thanks so much for the wonderful presentation, by the way.
Oh, thank you. I think it was a pleasure to get the opportunity to actually talk about these things. It's obviously a topic that's near and dear to my heart and the folks that we've been working with in the community. And I know that when I go out to community-based settings, some of the questions that have arisen are related to how do we do this? How do we integrate our services with mental health services more effectively? And my advice continues to be see if they will allow you to share, screen for brain injury, going in with the attitude that if people do screen positively, that you will help to address the needs that arise either through consultation or referral. And as a first step, before trying to design treatment programs or to send over referrals, has been really successful for us. I don't know. I can't see the screen, David. It doesn't sound.
We had somebody type. We had a couple people typing a question. I'm just waiting for them to finish up.
Oh, okay. Okay. Do you know if there's a way to see that on my screen?
It's right under your video. There's the chat box. So I'm going to read the first question from Stacy Minton.
Okay.
As an ACT worker, I think it is important that ABI be integrated into ACT services. I'm wondering how funding will be secured for this, as money seems to be the biggest issue with the integration.
I think that the services are probably going to start, and they have it reconnect using the existing funding. And I think that the way that that can be best accomplished is if we screen for brain injury in those existing clients, and that we use projects like the SUBI training project and some similar knowledge transfer initiatives to actually fund the existing staff complements to work better and more effectively with those folks. Getting more funding, I think the best strategy that I could think of is getting it on the addictions and mental health strategies, because it's my understanding that those are used as templates for vetting proposals for new funding. Is there another question?
There's
I
two more
hope that
being
answers the
written.
question. Okay.
Stacy is also wondering, are proposals being drafted to present to the LIN and the Ministry of Health?
We have one proposal in for what they're calling integrated funding. Oops, I'm sorry, I lost my webcam. For integrated funding, and that actually is that's still under review now. And my understanding of the potential outcome of that is we will get some seed funding to actually integrate our services and to track how our services are doing in terms of efficiency and client outcome. But that funding, it won't be for additional ongoing services. It'll just be to integrate our services. So what we're really hoping is that we'll be able to get that funding and collecting data on the clients that we're already serving actually justify the need for more investment.
Great, thanks. And Ashley De Batista would like to know, how can providers advocate for ABI inclusion on the mental health strategy?
Oh, that's a really good question. Keep bringing it up. And the way that we've been doing it is actually talking with the people who actually contribute to these kind of white papers. And strategically, that's why CAMH has been such a lovely partner, because if you look at the Canadian mental health strategy, they are all over that document, and certainly have been a primary author in the Ontario document. So when you have a chance and you're in those settings, doing what you can with frontline providers so that the word continues to get sort of from the bottom up and from the top down, that these are folks that are already being served and that require attention within more attention within current resources. Best I can come up with. Is there anything else there? Oh, I see. There we go. Now I can see the chat. Okay, so it looks like we've addressed the questions that have already been written. Are there any other questions or thoughts for discussion? We're actually 9 minutes over our time, and I'm pretty sure that people have very busy schedules. So I really appreciate the fact that folks really did stick with us. We still have a lot of our participants. And, there's a question now from Hetty. Most LINs have mental health collaboratives. Make certain they know about the research findings and the need for working with ABI. And that certainly is a great way to advocate for the need for mental health services for people with ABI. I think that's a good way also to address Ashley De Batista's question. On our screens, we can see some people typing, so I'm giving people a chance to type.
All right, Carolyn, I think we're going to end it now because we're a little bit over and everyone's got to get back to their busy days. Thank you so much for the
Yep.
wonderful presentation, and thank you everyone for joining us and for your questions and your attention. We hope you can join
Yes,
us
thank
when
you
we have
very
our
much.
next webinar series. I'm sure we'll have Carolyn back to talk about more of her wonderful research.
Thank you so much. Thank you, David, for arranging all of this.
No problem. Bye, everyone.
Okay. Bye-bye.